Hey everyone, my name's Shoaib. I'm the co-founder of BitePACES, and we have another webinar for you today. But before we kick off, I'm just going to quickly run through our course as we always do. So we have our in-person courses coming up in London, and we have a 3-day comprehensive and a 1-day intensive. And these have been particularly popular this time round. We've actually sold out of the 3-day in May. We have another 3-day in June, which is still available, and we still have some 1-day spots available. So please do come along. We've trained hundreds of candidates, and we have very highly rated feedback. And you can sign up for the courses here on this QR code, and I'll send the link in the chat. And you can also join our WhatsApp group where we post our free webinars like this one, and you can ask us questions as well. If you attend the webinar, you can get a £20 discount with this discount code. Yeah, 50 reviews, rated very well on Google, but I won't go into this in too much detail. What I want to tell you about is we have our webinar series, and this is done by our faculty, so people who actually teach on our course. Today we're going over a few tips for IMGs because the IMGs do fare worse off in the exam. And I think with a few tips and tricks, you can really optimize your performance. And Pranesh has been on our faculty for a long while now. He's very experienced. And I have no doubt that he's going to host an excellent webinar. Our next webinar is covering common cases. A lot of you message me about what cases come up in what center. So if you're interested, rather than going into each center, we're just going to do an overview of all the common cases, and that's going to be done by another one of our faculty members on the 6th of May. So please do sign up to all these webinars. I'll post links in the chat. Without further ado, Pranesh, I'm going to hand over to you. And when you're ready, you can take things away. Okay. I think maybe, okay, there we go. Okay. So Pranesh is,
Right.
you there?
Yeah.
Okay, fantastic. So Pranesh is one of our faculty. He's a renal registrar and very experienced PACES tutor. I'm going to hand over to you, Pranesh. Whenever you're ready, you can start sharing your screen.
Right. Right. So, thank you for the very kind introduction, Shweb.
No problem.
I'm just going to share my screen now. Yep. Can you see this now?
I can see it. Yeah, I can see it.
Perfect. Perfect. Are we ready to go, or should we wait for a couple of minutes?
I think that's good. We've got a decent number of people here. I think we should be good to go.
Okay. Yeah. Okay. Great. So, morning, all of you, on a Saturday morning. I'm not sure which part of the country you've joined. In Manchester, it's a beautiful sunny day, and um, you're all quite motivated to join on Saturday morning. And I wish you all the best. I'm going to try my best over next sort of some time to be as helpful as possible. If in the meantime you've got any questions, unfortunately I cannot see the chat, while I'm talking. But what I'll do is every once in a while I come off to see if there's something in the chat. But at the end we'll have a session of question and answers. If you've got any questions, I do suggest you either note it somewhere so that we can have a discussion about it. So let us start. Yeah, so the topic I have was top tips for IMG for PACES. So international medical graduates and PACES is a funny relationship, isn't it? So myself, Dr. Pranesh, and I'm a renal registrar ST5, currently in Manchester. So is there a peculiarity about IMGs and PACES? I do think there is, and I'll see. I'll try and show you how and why. So if you have a look at this, so this is from MRCP PACE's website. Out of every, in every exams, out of all the candidates, 70.9% are international medical graduates, which basically means anybody who's had their primary medical qualification out of the UK. In the second column, if you see how many pass compared to, I'll come to that. So, and out of all these, the candidate sitting in international center is 34%. Now, coming to the percentage pass rate. So if you see, For all the candidates, the average is 52.9. But for IMGs, it's slightly worse. Now, mind you, this all includes IMGs. So if you were to exclude IMGs and if you were to see what the performance is, IMGs versus non-IMGs, the difference would be, sorry, excuse me, the difference would be a bit more pronounced. And obviously, there is a specific difference in UK centers as well as international centers comparison, whether or not you're IMG or not. So this, I think, is peculiar, and this is worthwhile diving deep into. And I think if we have a look at this, and if you try and understand why and how, we may be able to crack this. So before we start, I want you all to think and ask a question to yourself. If, let's say, if there was somebody, if let's say I had superpowers and I was to ask you, what is that one thing that you want so that you can crack this exam? Just one thing. Okay, think about this, and either you can put it in the chat or you can tell me when we're done, and then we can discuss. But I am an IMG myself, and I have a bit of an analysis about this. What is PACES? PACES is an examination which tests your clinical skills, knowledge, and communication, which is non-clinical skills. There is no doubt about knowledge. The knowledge that is needed to crack this exam, all of us have. So it's not about knowledge. Now, clinical skills, that is something very interesting. A lot of us do think we do not have enough clinical skills. A lot of us think that we have clinical skills, but we struggle in clinical skills, even though we think we would not. And communication skills. I think this is that one domain that people are quite clear and quite, honest about that. Look, this is where I need help. But often it is something that we don't appreciate as a weakness that defeats us. So knowledge comes into the play when it is about differential diagnosis, discussion, management, and understanding of overall scenario. There's a good proverb: eyes do not see what mind doesn't know. So if your mind doesn't know, you would not be able to appreciate. Clinical skills is all, communication skills. Sorry, communication skill is obviously what you're talking, but it's not just what you're speaking. It's soft skills, your gestures, how you manage patient welfare, how you manage patient concerns. Now, this is also available in the website. Um, the exam is not an exam of stations, it's an exam of skills or domain. There are these domains, and there is a description of how and what is expected to be able to clear that that skill. So broadly, physical examination, identifying physical signs, clinical communication, differential diagnosis, clinical judgment, managing patient concerns, maintaining patient welfare. It is important to note that all of them do not have equal weightage. Some of them carry much more weightage. So the expectation is that you achieve at least 75 or 80% in some of them compared to just 60, 70% in some other. And we'll look at that in a bit more detail. I don't want to go into any detail of this, but if there is a question, we can definitely come to this. Now, when we compare the performances of UK and non-UK let's say UK graduates and all other candidates, which would include IMG, what can you see? So the things that there is a difference in all the domains, more or less, except maintaining patient welfare, which is, it's very difficult to fail that domain because you don't need anything to fail, which is why there's not much difference. What are the specific stations, or what are the specific domains you think? So one of them is identifying physical signs. This is the difference is 67.9 versus 73.4. Now again, this is all candidates, so it would include UK trainees or UK graduates as well. If you remove them, the difference would be more pronounced. So the UK trainees are much better in identifying physical signs. Similarly, in clinical judgment, differential diagnosis, as well as clinical communication. These four domains, I think, are usually the ones that trouble most of the IMGs. Now, was this an enigma? I do not think so. It is not something that we didn't know. So it's not that we've got to decode the enigma. But if it wasn't enigma, sorry. If I was to, if I was to talk to somebody who's never appeared PACES, who doesn't know much about PACES, what I would say, PACES is a fair exam. Although you see these differences, it doesn't mean that somebody's unfair. It is practically impossible to judge how good you are in 10 or 20 minutes in a specific station. Can anybody do that? We cannot. Which is why there is a system of calibration and marking, which is decided by the examiners independently just on the day of exam. So, what they do is they would come, meet the patient, they would examine the patient, and among themselves, they will decide that, well, I myself have been able to elicit these five signs. I would expect the candidates to at least, you know, elicit these three signs or four signs. One other thing to note is if it's a respiratory station, the rule or the system is it will not be a respiratory specialist. It would be a non-respiratory specialist who would be examining that station or examining candidates in that station. So they're not going to be specialists. So if it's not going to be a cardiologist who will be um, examining a cardiology station. So it is very much possible that you would be able to elicit everything or even more than what they have elicited. So this is when I say enigma, it is definitely something, and you need to understand the rules to play the game to be able to clear the exam. It is not a difficult exam, but it has a set of rules. Very, very important thing specifically for IMGs is what you articulate or what you say, it matters more than your knowledge or your skills. Um, Unlike real life situation when your knowledge is very, very important. Your knowledge be, would be held more powerful compared to what you articulate or what you say and how you say, but that is not what happens in the exam. We'll come to that again. So I think we all understand that there are two main domains. One is clinical skills, specifically identifying physical signs, and then there is non-clinical or communication skills. I'm sure all of you are aware of this carousel, but I've just, because it is spaces, I've just put this carousel. And you can see that all these stations have different domains. So depending upon which domain you feel you are weak in, or what you think is your strength, you can then focus on specific stations. Um, Again, coming back to the skills, if you think your weakness is identifying physical signs, you know what are the skills, what are the stations you need to. Um, so these are the stations again. As I was saying, if you know that so and so skill is your strength or weakness, you can then focus on that particular station. Now, this is the passing marks on. I'm sure all of you already know, but I just wanted to cover everything before we go ahead. So all the skills are not equivalent. As you can see, managing patient concerns, managing patient welfare, you're expected to get 28 out of 32. But yet you see that 99.6 or 99.7% people do very well in this station because all you need to do is make sure that the patient is not in pain or you do not hurt them or you do not be, you maintain their dignity. Compared to a station like clinical communication or identifying physical signs where the expectation is not that much. However, we still manage to struggle in identifying physical signs. Ever wonder why? I think we should. To pass this exam, you need to pass all these stations. Okay? Sorry, my mistake. All the skills. Even if you do not pass a specific station, you can still pass the exam, because what is important is the skills. As long as you managed to get passing marks in all the skills, you will be able to pass. Um, just like how we've seen, there is a lot of information about every station, what is expected. So station 2 and 5, which is consultation, it expected that you approach the clinical problem in an integrated manner. This is very important, using history, examination, and communication with the patient or surrogate. And then the station features, they will tell you what are the station features, how it is divided, and what is expected of you. In communication encounters, what they assess is your ability to guide and organize interview. We cannot be saying that, the person, the patient or the surrogate was talking a lot about something that very not, unimportant. It's they want to see how you are able to guide the interview where it should go. We've got to show that you've been able to understand the clinical information and then describe them to the patient. And then obviously comes the knowledge where you discuss differential diagnosis, the plan of management, and then you arrange an appropriate follow-up as well as investigations. You've got to involve family members when they have to. Similarly, you have to not involve them when you shouldn't, and you need to know the medical ethics, which comes handy sometimes. The other thing which I think is very useful to understand or see is there is an example mark sheet for all the stations which is available in the website. I'm not sure if they have got the new uh, PACES 23 mark sheet, but this is how it is described. So it is very objective. It's not it's difficult for somebody to fail because of a specific examiner, because it is so crystal clear that if, let's say, coming to, let's say identifying physical signs, which is one, two, three, four, fifth, it says what is satisfactory, identifies correct physical signs, and they would have written what are the physical signs you need to elicit. Does not find any signs that are not present. So you get too excited and see, oh, this is a kidney transplant patient, and you say that um, there are two scars, I can feel two kidneys. So you say that, oh, there are two globular or ballotable, or you shouldn't say ballotable, but you could say two bean-shaped or globular structures in both iliac fossa, which I think corresponds to a bilateral kidney transplant. But you didn't note that one kidney was removed. So he only has one kidney and the other kidney was removed. This counts to, discovering or inventing science, which is an unsatisfactory finding. So unsatisfactory is missing as well as finding signs that are not present. So it's that easy. Where does it become slightly gray is when it comes to communication, because communication unsatisfactory says omits important areas of history, unpracticed, unprofessional, poor explanation to the patient. This is slightly gray, and this needs a lot of practice. Coming specifically to communication, this is again, I think you can all see and find this in the website. From communication perspective, what I found useful is when I felt I was struggling, I just went through many cases of breaking bad news. Where what is very important is offer a relative to be present, or spouse to be present if you are breaking bad news, and they you think they're going to need help, they're going to need support. But it's definitely useful to ask. They may deny, but you should ask. That has to have a specific point. It's also important that you give a warning shot. These things have points: misdiagnosis, delayed diagnosis, end of life, advanced directives, DVLA, mental capacity, ethics. Ethics is something that a lot of us take it for granted. I would suggest that it's very easy. If you just make it a point of going through ethics once every 3 days, you will be excellent. As long as you obey the medical ethics, you will most likely always comply with the good medical practice from GMC. If you don't know or if you're not aware of good medical practice from GMC, I highly recommend you just Google good medical practice GMC and you'll get to a page where you'll find, and that really, really helps. What is not mentioned is duty of candor and confidentiality. And often that becomes a point in exams because it is not in ethics, but is in ethics somehow. The duty of candor, if something, somebody has committed a mistake, it's your duty to tell the patient because patient has rights to know what has happened. Similarly, confidentiality, it doesn't say confidentiality has to be, obeyed. However, if it's about a greater good or public health, what are the situations when you can, you know, make confidentiality as secondary, and what comes prior, what comes in first place. Now, all these things I've told you is based on my struggles as an international medical graduate. So I was almost a consultant in India when I decided to come to the UK, and I didn't have PACES, or I didn't have MRCP even part one then. So I did all my steps once I came to the UK, and these were my findings, or these were my hard learned lessons. Although one size does not fit all, but for some peculiar reason, I've noted in my years of practice, in my years of being a tutor, in my years of guiding the junior doctors, I've noted that there are a lot of similarities for some reason. I did not have an organized approach, neither in, when it comes to in paces, neither in examination, nor in eliciting signs, nor in presentation, nor in discussion, which was the biggest hurdle. Presentation. Now, when you are in clinical practice, your colleagues or consultants would know what you have elicited, what you're talking about, even though you're not able to say it in a proper way. But examiners have limitations. You need to articulate in a specific way for them to, tick that, well, this is done. Communication skills. I think I struggle with communication skills a little bit initially, but as I said, a lot of us already identify this. Maybe because English is not a first language, we work a bit more on communication skills, and somehow we do very well in communication, but we then sacrifice or somehow do not give enough attention to identifying physical signs because we either overconfident, I don't know, either overconfident or we didn't give enough attention. Coming to clinical judgment and differential diagnosis, now this, it's not about knowledge. I think it's about way of thinking, and this comes natural to you when you know how NHS works, how the healthcare or how the framework is built in the UK. And this would basically need a lot of learning. When can you bring somebody to an ambulatory or STEC? When can you ask something to be done by the GP? When can you refer them to so-called seizure first fit clinic, physios, OTs? There are many of these things would come into play. These subtle things, these subtle things can cost you confidence and cost a lot. But if you, I bet you only if you give 1 week to these things, there will be enough. But because we kind of are not able to identify these problems, we're not very confident in our approach, or we are overconfident without knowing this. So, for instance, somebody's got a pyelonephritis. Do you think they need admission? If not, why? And if yes, why? What are the criteria when you admit? Peculiarities of, so in India there are many conditions that I thought were very, very important from examination perspective, but they were not important here because they're not common here. Similarly, there are common conditions here. There are problems which are peculiar to this setup, which you need to understand and which you need to be as good as the UK graduates, specifically the health problems in elderlies, because the population here is a bit more in the aging, or let's say the expected life is a bit more here. Then one of the very, very, very important things is demonstrating what you saw and understood. So, just to give you an example, myself being a renal registrar, I saw JVP very quickly, but the examiners didn't think that that was enough time. So they felt that I saw but I didn't appreciate, which is which is classed as not identifying. Similarly, pedal edema, there is a way to show the examiner that you have elicited and you understand. Okay, so which is why it is very good practice to tell them things that you have identified, whether or not you eventually find that useful, they were contributing or not. And I'm a big Sherlock Holmes fan. So Sherlock Holmes is not Dr. Watson. And I bet if Sherlock Holmes were to take paces, he would fail because he is observant, he observes things, but that is not what is needed. What is needed is you be able to tell everything that is important. One of the things that a consultant then fed back to me was I thought like a consultant rather than a registrar. What is expected of you is to think like a registrar. You so if somebody comes with a seizure, you can't straight away jump to rare diagnosis. It's your responsibility to ensure that this person is safe for next 24 to 48 hours when he can be seen by a consultant. So you've got to leave stuff for consultants to do. Uh, you can't think or behave like a consultant. Another thing that it could be subtle. So in my country, when you are with a consultant with a senior, you are respectful, and being respectful could mean or could be taken as not being confident. It is a little bit subjective, so I wouldn't delve deep into this, but make sure that uh, you have to appear confident. You cannot just because being respectful, you cannot be. Uh, you have to appear confident. Now, just quick tips on specific things, physical signs. What I suggest you do is look a lot of videos and then appreciate the subtlety of how somebody is examining and then how they are appreciating and then eliciting the signs. Demonstrate first without time. So when you go for practice, in your with your study group or with your study buddy, go and elicit signs, go and do physical examination without worrying about time initially, but then you have to very soon start to do the same with stopwatch. So you've got to time yourself. You've got to get into the habit of examining people in a specific time, and of course, seek professional help when you think you can't. Presentation. This is a very, I think IMGs struggle the most in presentation, and because we do not present, because the IMGs do not present appropriately, it is thought that well you've missed a sign, you've not talked about this, your judgment is not to what I expected. So broadly, there are two ways of presentation. One is a confident, or let's say when one is when you know what is the diagnosis, one is when you do not know or when you're not sure what is the diagnosis. Now mind you, you cannot be sure on something that needs more investigation or something that is a diagnosis of exclusion. So both of them are correct in specific environment. And just to give you a bit of an example, so one of the ways is that you say diagnosis first that I think this person has got so and so, which is based on these positive findings and these negative findings. And then you can say everything else. When you're not sure what is the diagnosis, you can say that, well, I've examined this gentleman who's come in with problems with his gait, and I've noted that he's got so and so, so and so, so and so. And when I asked him to make an Archimedes spiral, I felt there was this. And based on this, I think this person has got idiopathic, or I think this person has got Parkinson's disease with possibly Parkinson plus syndrome, whatever. So they're both correct. You, they're both correct. Personally, I feel that if you are being examined, or if you're taking exam in the second half of the day, I think it would be a good idea to not depend on not waste time and make sure that you hit the ball sooner. Unfortunately, there's no shortcut to this. The only way is practice, practice, and practice. Communication skills, again, need a lot of practice. What I would suggest in general for every station, it's a good idea to have a pro forma structure. So what I did is during the last month of my exam preparation, I had a book and I had a pro forma for everything, even if it is an examination or a history. So when I did, it was history taking separately with communication skills also separate. So when it's a history taking session, who am I? Am I a medical registrar in a clinic? Am I a medical registrar in the ward? What setting is this? Who is the patient? Or if it's a surrogate, or if it's a patient relative, what is the question being asked? What are the salient features, or what are the things that can become a problem? Things like this. So I make a pro forma of 8 or 9 points, and then I practice every day so that the pro forma gets embedded in my way of thinking. And only when this happens, you think the way you have to present, and you're very easily then able to assess the problem and collate all the findings together, and then you can come with this. Helps specifically in neurology because it's easy to get overwhelmed when you're not sure. And then a lot of other things about communication. You've got to ask open-ended questions, listen actively. You can be sorry without being wrong. So if something wrong has happened to somebody, you can be sorry. Avoid confrontation or judgment in difficult situations, and empathy is the key. Empathy again is, I think, one of the things that IMGs can struggle a bit with, which comes quite naturally to the UK graduates. Now I've got a sample scenario, but I think it's probably not the best time, or it's probably we've got to um, yeah. So can you all see me? Yeah. Okay. Does anybody have any question, or does anybody want to ask something? Feel free to just either unmute yourself and speak or put something in the chat. I have a weird feeling that were you all able to see the slides? Yes, can't see the slides. Yes. Okay. Right. Anybody has any question, or anybody would want to discuss something, or share their experiences? How would you want to uh, you know move forward? If if not, I can just yeah. Yeah, please go ahead. Go ahead. Somebody has got hands up. Yeah, Mina. Yeah, go ahead.
Hi there. Hi, everybody. Good morning. I just want to share my experience in an exam last year. It was a communication station, and the patient was a young 45-year-old gentleman who had uncontrolled high blood pressure, had collapsed at work, and came into hospital, found to have a massive subarachnoid bleed. And the task was to speak to the wife, who didn't know that the patient was in hospital. And I went down the route thinking I was, trying to think out of the box. So I approached her, slowly, tried to gauge her understanding of the situation. So she had no idea what had happened. She only heard from the office that her husband was in hospital all of a sudden. So I explained what happened. And then I thought, I felt like there was nothing else to talk really. So I thought, if he's had a massive subarach bleed, there may be a chance that we need to talk about potential, if he had discussed with his wife about organ donation, that sort of thing. And then I realized that much later, obviously, I realized that I had broached a completely different topic.
Too far, yeah.
Yeah, I went too far. So I apologized, I offered a cup of tea to her, and then I said, has your husband ever discussed organ donation with yourself, that sort of thing. And I took it down that way. Then I concluded the communication station by asking, do you have any other questions? These are the supports that will be offered, etc., etc. And she said, no, I was fine. But when I looked at my feedback, apparently the patient was the surrogate was devastated. She didn't feel comfortable with me. So
Yeah. So very, thank you, Meena, for sharing this, first of all.
yeah,
I am sure the first person to have found difficulty in communication,
yeah,
and it was not an easy station, to be very honest. But
yeah.
I think so. I was going to share some of the slides on communication, and I think we should let's just take 1 minute, and I'll quickly skip through. So what I want to show you is
Hmm.
that every communication station is designed in a specific way, and it is the way it is designed. Can you all see my slides?
Yes.
Good. So, the way it is designed is there is a candidate brief which is given to us.
Hmm.
Then there is scenario, and then this bit is all which is given to either the patient or the surrogate. They can see what is the candidate brief, they can see what is the scenario. They're also told what is going to be their attitude and emotional response. And then the most important bit is they are specifically told to ask these questions. And then there are questions that they will ask only if you give them a chance or only if you hit the right spot. Okay.
Okay.
And this is what the examiners have. These are the things that the examiners want to see you, touch on. So I think what happened with you is that you're not sure, so I think um, what what would have been helpful is if you would have if you have practiced that station before, but it's not possible to practice every station before the exam. So, and I noticed this happens. So what I did is, the performer that I was talking about. So the performer would be you are a doctor, you've got patient's wife, and if you read the vignette properly, it says specifically what's your task. So, for example, if we go back to the station that we were discussing, um, give me a second, I don't know what's happening. Where did it go? Um, give me 1 second. Yeah. So if you see this, it says your task is to explain the implications of the TIA, discuss secondary prevention strategies, and address his concerns about lifestyle and stroke risk. So this is what you have. Okay. And this is exactly what your task is. It tells you that the problem is that he is concerned about the risk of having a full stroke and is unsure about making lifestyle changes, particularly quitting smoking. So these are the information that has been given to you. And to the patient, it says that you are anxious about your health but unsure about making lifestyle changes, especially giving up smoking. You want reassurance but feel resistant to the idea of quitting smoking, particularly as it helps you stress from work. It helps the stress from work. And then the question you want to ask and stuff like that. Your attitude, so you're anxious. So I think what if you have a look at the question vignette once again, you can see what is a specific question that needs to be answered. And as I said, there are questions that you've got to answer. There are questions that they will definitely ask, and then the questions that they will ask only if you give them a chance. So if you ask open-ended question, if you think it also answers, also going to answer one of the questions that's put on the chat, which is by Anjana Razik. So any recommendations for perfecting the communication, especially when the examiners appear tough? I think whenever there is a whenever you think you are in a difficult situation in a communication station, what you need to do is take pauses. Pauses are very powerful tool. If you do any professional communication, course, you'll understand how powerful are pauses. Pauses does two things. One, it gives you a bit to understand what's going on. It gives a bit of time to the person in front of you to digest the information and take it, sink it, let it sink, and then you can always reassess. Am I, this is what you can just rebuild, or you can just give shots that, for example, in your situation, Mina, can you just remember what was the question once again? What was the exact task for you? We seem to have a bit of problem, but I think, if let's say if it was of updating or telling the partner that they've been admitted with hypertension, you would want to just focus on that question initially and then slowly build around that if there was any other question. And then make sure you ask open-ended question. Is there anything else you wanted to ask? Is there anything else you want me to discuss? Is there something that you are worried about? Do you think you want help with something? If you ask these open-ended questions, that would be very helpful. By Anjana Razik, any tips to manage stress on the day of exam? Um, I think it's normal to be stressed. I think
Uh-oh.
being stressful. Hi, sorry.
Sorry, I'm with a toddler.
Yeah, no, no
Sorry.
problem, no problem.
Yeah, so the specific question was to speak with the spouse, essentially.
Yeah,
Uh,
and
and to
yeah,
basically speak to the spouse and answer their questions. So I
yeah,
did, intermittently, like you mentioned, pause. So I paused, I offered a cup of
yeah,
tea, and then I asked some open-ended questions. But
yeah,
I think I just went down the wrong,
yeah, yeah, yeah. I
yeah,
think I agree. I think I see what you mean,
yeah,
and I think it's very important to specifically focus on the question and the situation,
yeah,
because if you take one, it is so none of us are perfect.
yeah.
Not even, I bet even the examiner, if you put the examiner on your situation, they wouldn't do everything that a different examiner would have thought was correct. So
Yes,
there's no 100% right, and there's nothing, uh, there's no set route as
yeah.
long as you reach the destination. So the destination is to update the family and ask if they've got any questions. I bet there was a specific thing that they wanted you to cater to. So
Mm,
if you ask them open-ended questions again and again, and if you
mm,
just take one short step, so I'll just share one of the instances that happened with me in my exam. There was a history taking station, or I don't know if it was a communication station, but very soon into the station, I was done with the task, and there was nothing left. The surrogate, or the actor, kept on looking at my face and smiling, and I kept on asking, "Is there anything else you want me to do? Is there anything else you'd like me to ask?" And then I just summarized the whole situation once again, which is again a good thing. If you Whenever you think you're in a difficult position, just take one step back. If you want, you can have a look at the scenario once again, read it, and then you can just summarize everything in 15 seconds. That this is what has happened, and I'm here to talk to you about this. Would you want to ask something, and just take it from there.
I think that's very
um
helpful. Thank
and no problem. So coming to the stress on the day of exam, I think what usually helps is, so when you're confident and you know what is going to happen, you're going to be less stressed. When you are when you're unsure of what's going to happen, you can be stressed. A very nice thing somebody told me is, if you go prepared for the unexpected, you will never be stressed. If you go confident, and if you just imagine that you're in at work, when you come, depending on where you work, if you work in SDEC, if you work in MAU, when you go in the morning, everything is unexpected. All the patients are new. You don't know anything about anybody, but you're not that stressed. But you are stressed in exam. You're stressed because you're worried about the outcome of the exam. You're stressed because you have decided, you set some standards for yourself, and these are often, it's yourself who have, who have, sorry, who has, made high standards for yourself, and then you are stressed that, will I be able to do this? Will I be able to do that? I hope that answers. If not, just raise your hand and or unmute yourself and speak. Irfan, Salim, any recommendations for perfecting the communication like a resource? Yeah, so um, there are courses. I think what would really help is, so communication is a big domain. For example, medicine. Any recommendation to perfect medicine? Yes, there are books, there are resources. What you need to identify is, what is your weakness. Uh, there are weakness specific in the, in the communication domain. There are specific weaknesses. You identify your weakness, and then the best thing is to practice with your consultants or colleagues. And then if you read all these stations, if you read about breaking bad news, there are a handful of scenarios that come again and again with some modifications. So if you read them, there are some techniques, for example, ice spikes and stuff. If you read them, you would be able to crack it. If not, I think it's best to seek professional help. BitePACES themselves have these courses which focus on communication station. In fact, I remember I myself have done a webinar on communication as well. So I'm sure if you when we ask, if you tell that you'd like on communication, we can talk about communication as well. Ayush Bhaskar, in my communication session, the surrogate started speaking what he was given in the written and was not letting me speak. I was wondering whether I should interrupt him or just let him finish this. How to deal with such scenario? So yeah, so what is expected of you is, being a doctor, you you could guide, you could guide the next 10 minutes. So what I would do is, it has happened with me, and it often happens with people uh, who are more polite. Um, so what I learned is, I learned it from what my friend, when we were practicing, and I saw him doing this. So one tip of the record to you, Ayush, is you can do this with your study buddy. You can, talk about some rubbish when you're a surrogate and see how he deals with it. You can do this to anybody and then see how they deal with it. And that is, very, very good learning, which is what I did. And one good thing I've learned is, when they're speaking, you do not want to interrupt them sounding or looking appearing rude. Like, for example, you're the surrogate and I'm the candidate, and you're saying, so and so, this, this is happening with my life, my wife, my work. I'm so sorry. I'm so sorry, Ayush. It's happening with you. I'm going to come back to all of that. This is a very good thing to do. I'm going to come back to that, but can I just make sure that I understand the situation and the problem appropriately? So I'm just going to ask a few questions. This is how you can redirect the whole situation. I hope that helps. If not, just unmute and ask. there was a hand I thought somebody raised. Would you like to ask, or would you like to share what exactly happened and what exactly was the question and what exactly was surrogate doing, Ayush? If you want, you're very welcome to do that. Anybody, guys, if any one of you wants to unmute and ask or speak, please do. We've got a hand,
Hey, Pranesh,
which is,
it's my hand.
yeah.
I just thought I was just listening in, actually. I wasn't planning on sticking around, but it was some really, really good facts. And I was just wanted to echo some of the things that Pranesh said, in that, like, IMGs have all the clinical background, and I've got to say this at the beginning, but actually, like, some of the best doctors I've worked with are actually often from abroad, like subcontinent, the kind of Middle East, all over the world really. But it's just refining these techniques because the culture is different here, right? As Pranesh said, it's about showing what you know in the exam, and when it comes to communications, it's about navigating these difficult scenarios. And time again, the same things come up. So one of you is definitely going to have a breaking bad news, advanced care planning, dealing with side effects of a medication, dealing with a mistake, explaining a procedure, explaining a diagnosis. These things come up time and time again, and you should definitely be able to practice them with colleagues. And yeah, we do run communication courses where we cover a lot of this stuff. I would say, like, definitely practice with your colleagues though, because that's where you're gonna get the most value. Make your own scenarios. There are practice scenarios online. We have scenarios as well. Just you work through them on Zoom, and it's something that actually you can get through really quickly. And what you need to remember, there's no Viva on the communication station as well. So that's one less stress that you need to worry about. I think one of the mistakes that IMGs make is they often go into too much detail. So I know one of you was saying that you started talking about organ donation in the context of a subarachnoid hemorrhage. It's definitely a good thought, but I don't think you need to think about what is the examiner wanting from this station, and I don't think that's the direction they would want it to go in, right? So it's just about getting in the examiner's mind, and even thinking about like clinical practice, as Pranesh said, in SDEC or MAU or whatever. What are you realistically going to discuss with the patient, at that moment in time when the relative has had a subarachnoid hemorrhage? As an example, I was just picking on that one, not for any reason, but it's just the one that stuck out in my mind. But yeah, no, it was. I think that was really useful, Pranesh. I don't know if anyone else has any questions. I think probably you've answered most of them. Okay. Is there anything else you wanted to add, Pranesh?
No, just going to close it. So I think it would, if any of you had a specific thought about something, or if you would like to have more webinars on a specific situation or station, please do make sure you join the group. First of all, you can get a lot of advice and help in that group. You can keep yourself updated with the upcoming webinars and courses. And also, if you share the what are the things you need, or what are the things you would expect, or find helpful getting webinars, then you can share. I was just going to share my slides. My presentation had last two slides. One of them was thank you, and the other had only a quote. And I'll just share the quote here. And I'd like to, this would be my last last thing to say. If any of you have any questions, comments, if you'd like to, know about something, hear about something, please feel free to ask now, or you can email later. I think we're ready. We're ready to close, right?
Yeah, brilliant. Thanks a lot, Pranesh. I think you'll all join me in thanking Pranesh for that amazing webinar. He's actually one of our, I would say, experts who teaches on our communication skills course. So Pranesh is kind of the perfect guy to take you through this sort of thing. And hopefully we'll see some of you at the in-person courses. Pranesh will be there, I'll be there. And if not, if you can't make it, maybe you're not in the country, or you don't want to go on a course, we have these free webinars for you, so not to worry. You can always reach out to us on the WhatsApp group, ask us any questions. We're both there. But well done for tuning in on a Saturday. Thank you so much, Pranesh, and thank you to everyone attending. I think we will close it there. So yeah, cheers, everyone.
Yeah. Cheers. Right. All right then. See you, Shoaib.
See
Catch
you.
you.
See you later, Pranesh. See you. Bye-bye.
Bye.